My name is Dr. Ian Storch. I'm a board-certified gastroenterologist and osteopathic physician, and you are listening to Do or Do Not. If you are interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode.
My name is Violet Sullivan, and I am a first-year osteopathic medical student at the University of New England College of Osteopathic Medicine, and you're listening to Do or Do Not. Today we have a special guest, Dr. Nicholas Elwert, DO, MS, who wears many hats in the field of physical medicine and rehabilitation, PM&R. Dr. Elwert is an assistant professor at the University of Kentucky, where he also serves as the Stroke Rehabilitation Program Director and Associate Residency Program Director. With a deep passion for neuro-rehabilitation and spasticity management, Dr. Elwert brings a wealth of knowledge and experience to today's conversation. In this episode, we dive into the world of PM&R, exploring what a typical day looks like for Dr. Elwert, the kinds of patients he sees, and how his work makes a difference in their lives. We also discuss his roles at the University of Kentucky, from teaching residents to shaping the future of the PM&R program. For students interested in pursuing a career in PM&R, Dr. Elwert shares valuable insights on what it takes to match into this specialty, the qualities residency programs look for, and advice on preparing a competitive application. We will dive into Dr. Elwert's personal journey through osteopathic medical school at Lincoln Memorial University, DeBusk College of Osteopathic Medicine, his fellowship in OMM and anatomy, and how these experiences shaped his career in academic medicine. This is a truly inspiring episode.
My name is Suzanne Char, and I'm a third-year medical student at Ohio University Heritage College of Osteopathic Medicine. And I have the pleasure of interviewing Dr. Nicholas Elwert. Dr. Elwert, welcome to the Do or Do Not podcast. How are you doing today?
Hey, I'm doing great, Suzanne. Thank you so much for having me on today. I'm just honored to be talking to you about something that is near and dear to my heart.
Can you tell us a little bit, what is a PM&R physician? What type of patient do you see? What do you usually do?
The field of physical medicine and rehab is very broad. You can have physiatrists that are doing sports medicine and sideline coverage, to someone that is taking care of a traumatic brain injury patient, or someone that is suffering from a functional standpoint from cancer rehab. At the end of the day, if you were to sum up physical medicine and rehab, I would sum it up that we are the doctors focusing on quality of life. And that is really where our niche is and what we do. So for me specifically, specialize in neuro-rehab with a focus on stroke rehab. So someone that has suffered from a stroke, they go to the acute care hospital, and based on their deficits or what issues that they might have, then they're coming over to the rehabilitation center, and that's where I come into play. And so I'm working with those patients on the inpatient setting, helping them get back to feed themselves again, helping them put on their shirt again, helping them walk. And so all the things that honestly we sometimes take for granted, those are the things that myself and our entire team are doing to help get this patient back home. And then in the outpatient setting, I follow up with those patients, which is an amazing feeling. You really get the chance to really bond with families, and you kind of become a family member. I always tell patients that I'm going to treat them as they are my family. So I'm treating them and making decisions as if they're my grandma, my grandpa, my mom, my dad. And you really get to see that when you're following up with patients in the outpatient clinic. And then things arise after a stroke. Someone can develop tight muscles or a condition called post-stroke spasticity, or can have spasticity for other reasons. And so that's mostly what my outpatient clinic is following up with my patients from the stroke unit, or have seen new consults, patients that have had strokes and some functional issues. And then also have some other patients that have spasticity management needs.
Can you take us through a typical day? What does that look like? An average day or an average week in general?
I'm currently our stroke rehab director and specifically work with the University of Kentucky Residency program. And so stroke is a core principle with PM&R residency. And so I have a resident and typically a student with me. And so my day typically starts between the hours of 7 to 8 a.m. Before I start rounding, I'm looking at all the vital signs, looking at messages that we may have received overnight, obviously touching base with our on-call team to see if they had any issues. And then I go out and I round with the team with a workstation on wheels, and we're taking care of issues in the moment. So orders and notes, we're going out and we're seeing patients. I love to see patients in the gym just because that really gives you an idea of how a patient is transferring, how they're walking, what things can we do in coordination with the therapist to get someone more functional. And then we're addressing all the things that can happen after a stroke. So post-stroke pain issues, spasticity issues, like I mentioned. And so we're doing that. And then we come back, we run the list together as a team. I feel like as a resident and a student, there's really no need to just say, okay, you're going to write all the notes. See you later. You have to learn how to write a good note before you start doing more and more. And then this is where, depending on the day, my day takes a couple of different paths. Some days after that, we're doing some whiteboard teaching, whether that is discussion on stroke syndromes or tube feeds or and then working on admissions. And then 2 days during the week, after we round and we take care of some things, then we go down to clinic. And again, we're seeing those patients either following up from a discharge from the rehab facility or new patients or different types of procedures that we're going to do. And so those are 2 days. And then the other day is we have an interdisciplinary team conference called ITC. So this is where we, as the medical team, will meet with nursing, all the therapies, case managers, our rehab counselor, and this is where we're updating everyone on the progress of our patients. Now, of course, on the stroke unit in our particular team, we do this on a daily basis, but we formally do this in this meeting. And this is where we're coming up with discharge plans for our patients based upon how long insurance has covered for them to stay. And then those days after those meetings, we're coming back, working on admissions, etc. So a couple of days of clinic. Otherwise, we've got some dedicated education days on top of educating during and teaching during rounds, and then have our interdisciplinary team conference days.
So you already mentioned a little bit about patients who have stroke. Do you see other patients with other conditions? And can you just give us...
So me specifically, I have a large focus of stroke patients. Then in the outpatient setting, this is where I will see some patients that are coming in for spasticity management. So whether that is utilizing nerve blocks or botulinum toxin or cryoneurolysis. So patients that are coming to us for some type of spasticity management. Now, as I mentioned in the beginning, what I do is one small sliver of what PM&R docs do. So I have colleagues that are specifically taking care of our patients that have suffered from spinal cord injuries. We have a team that specifically takes care of patients with traumatic brain injuries or have complex medical issues. And so mine is one small sliver. And then that's just talking about the inpatient side of what we do. I've mentioned a couple of times what I do is as an outpatient PM&R doc, but then we have some docs that just do outpatient rehab management. So whether that is musculoskeletal care on the sidelines with our sports teams, that's my normal day and my normal patient population, but that is a small sliver of what we do in physical medicine and rehab.
Sounds like students who are interested in it can go really in so many different directions.
Yeah, and this is where when I always am recommending to students, come into residency, not only just PM&R, but in general, with an open mind. My story is I thought I was going to be a outpatient musculoskeletal and interventional pain doctor. I thought that I would do interventional spine management with musculoskeletal medicine. That was what I had set my medical school activities and beginning of my residency. That's what I had done, all these activities to set myself up for a fellowship application. But I had a really important mentor tell me, Well, wait till you experience all aspects of PM&R. And I'm so glad I listened to him because that's where I fell in love with stroke rehab and the team aspect of physical medicine and rehab. Don't get me wrong, I would really enjoy being an outpatient musculoskeletal doctor, doing interventional spine and just interventions in general. But I'm passionate about stroke rehab. And to me, there's a difference between really enjoying something and being passionate. That's my story. So it was really my experience here at the University of Kentucky that helped mold me into what I am today and what I do. And in all honesty, I'm forever grateful for that.
Can you tell us a little bit about calls for PM&R? What does a call mean to you? How often do you get those phone calls or have to go to the emergency room?
With a part of being a neuro-rehab doctors, we have some patients that also have their spasticity managed with intrathecal baclofen pumps. And so there's a couple of different schedules when you look at different call schedules. But for me particularly, I am in our baclofen pump on call. And so what that means is about once every 6 weeks, I am on call with a upper level resident and starting in the evening on Mondays. And that's where we are addressing any types of issues that come up. So whether that is a patient is at home and is having some issues that they need us to take care of, or if someone comes to the emergency room because they have some type of medical ailment and they happen to have a baclofen pump, we are called to just see if there's anything wrong potentially with the pump. So that's my week when I am on week call. I tend to have a black cloud when it comes to being on call. And so it's not uncommon for me going in maybe once or twice a week, interrogate a baclofen pump. I'm trying to see if there are issues or answering some outpatient calls. And then on the weekend, I am on call with one of our other residents, and that's where we're taking care of a group of patients. And so particularly here at UK, I'm covering patients that are on the stroke unit, the brain injury unit, and the complex medicine unit. And so that's where myself and the resident will get here around 6:30 and start rounding. We'll see all the patients that we need to see. And then we come back. I start looking at labs. The resident starts working on admissions, and it's a real tag team effort. And so that's what a call schedule looks like for me. And then sometimes I have to go on the weekend into the acute care hospital managing pumps or other issues.
Does that mean when you go in, like you're spending only a couple hours, fix the thing that you need to fix, the pump, and then go back home? Or do you usually stay for longer hours on your call and go through like multiple patients? Or
That's a great question. So it really depends on what the issue is. If someone is coming into the hospital and they have sepsis due to a pneumonia, but they also happen to have a baclofen pump, that's a pretty come in. We make sure that their symptoms are in fact due just to the pneumonia and that there is nothing wrong with the pump. We're coming in, we're evaluating it. If it is most likely not the pump and it is probably their pneumonia, which is normally the case, that's what we do. Now, if someone comes in and let's say, for example, they are in autonomic dysreflexia because they're a spinal cord injury patient and that's an emergent condition, I'm going to be there a little bit longer trying to make sure we identify, okay, what is the issue that's going on? What do we need to do? So really depends on what is going on with the patient. The longest I've ever been at the hospital has probably been 2 to 3 hours. And that was me just staying, making sure that I was checking in on the patient a couple of times. I looked at some labs that we had requested come back.
you're an osteopathic physician.
Yeah.
So how does the osteopathic principles and including OMM, if any, plays into PM&R?
OMM and being a DO blend so well into the PM&R field. Being an osteopathic physician is something that is near and dear to me. I love not only the medical knowledge that I obtained in medical school, but then also the hands-on training that I got. And that hands-on training can be used not only for utilizing osteopathic manipulation, but then also you got to use your hands to find where that joint space is. And you're doing some guidance techniques. So saying, this is what I'm feeling. This is probably where I want to start. This is where I want to put the ultrasound. So just having that tact skills is very important. And so to me, it's a perfect blend. I still do osteopathic manipulation on my patients. And so that is something that is another thing in my tool bag that I'm able to use and provide for my patients.
Can you tell us a little bit more about your role at the University of Kentucky?
I am our Associate Residency Program Director. So I love teaching residents and students. That is something that I am very passionate about and love doing. So I'm honored to be serving in that role. And then also, I serve as our resident research advisor. So as residents are going through residency, we're having quarterly meetings talking about how their research projects are going, what resources they need, different conferences they're presenting at. And so that's been a role that I definitely love doing and love showcasing our residents' work. And then within the university and here at our acute inpatient rehab center called Cardinal Hill Rehab Hospital, I serve as a stroke rehab director. So meeting with leadership from the stroke unit and leadership at our hospital as we talk about our core measures, talking about different resources that the community needs. And so those are the three big roles that I play here at the University of Kentucky.
Can you tell us a little bit more about the program that we can't really see on a website or quick Google search?
So the first answer is the people in the atmosphere. I know a lot of people will mention that, but man, we really make sure that not only are you supported, but that your family supported as well. I can tell you tons of stories when I was a resident. When we welcomed my son into the world, we unexpectedly spent some time in the NICU. And just the amount of support that I got at that point as a resident was overwhelming. It was unexpected. I had my schedule all outlined. And then all of a sudden, we were in the NICU. And then all of a sudden, while I'm trying to figure out, okay, how's my son doing? And what does my wife need? Worked, also worrying about that until really quickly, our program chair and our program director stepped in and said, hey, Nick, take care of your family. You guys are in our thoughts and prayers. Whatever you need, let us know. And don't worry about work. We've got it covered. And so that wasn't me reaching out. They did that on their own. And that's just, again, one example. One is the atmosphere. Dr. Key, our program director, has this saying, which I think is so great. We want to graduate great physicians, but better people. And so it's really that philosophy. You have to be a good person. And by being a good person, you can be a really, really awesome physician. And so we really take pride in that statement. And then if you're a numbers person, you get so much procedural volume and then just volume in general with patients, with all of the patients that university serves. There are patients that are very, very sick that come to the hospital. Well, they need rehab. And so we get the opportunity to help them and to step in as well. And so you get that training, right? At the end of the day, you don't want to go through residency and then find yourself having to go to up to date to treat something that might be what I would say maybe quote unquote bread and butter. You're not having to do that. And as I provide that answer, I sometimes get the question from students, how do I figure out how well prepared residents are? And my one advice is look and see what their graduates are doing. Did you have graduates that are all going into fellowship or all going into private practice? Really gives you an idea of maybe the focus and the experiences during residency, and that can help you as you're on the interview trail or as you're looking at programs as to what might be the best fit for you.
Your program is really the family-oriented program. So if a student listening to this episode is like, well, that sounds really cool. I want to be at this program. You review probably hundreds of applications through each FASH season. What do you look for an applicant? Which applicants that really stands out? It's like, okay, I want to interview this person. I want them at my program.
Some of the common key characteristics that I'm looking for is someone that has a good work ethic, someone that is compassionate, and someone that is humble, someone that has had some experience, maybe working with patients with disabilities. So maybe that is volunteering at a nursing facility, or that is being involved in the Special Olympics or different types of camps. I'm really looking for those experiences. And then also taking on some leadership experience. Like you have the opportunity to lead a student interest group or lead a study group. You will learn some really key characteristics that will really follow you throughout your residency and throughout your practice as a physician. And then also teaching. I'm not looking at teaching as, hey, this person for sure is going to teach, or going to go into academic medicine. That's what I'm referring to. We have to teach as physicians. We have to teach not only if someone is a part of a residency where we have residents and students, of course, you're going to teach, but we also got to teach our patient. That doesn't matter where you're at. And so having that ability to at least have the discussion and teach is critical no matter where you end up as a physician. And so those are some of the things. Also, do they know about physical medicine and rehab? What drew them to the field? And just seeing that passion really come through, whether that's through a personal statement or through experiences. Those are some of the things that I look for.
Do you look at all research or scores? Because we know COMLEX or STEP2 are still score. How much those two aspects play a role in selecting a good candidate for a program?
Yeah, I think that's a great question. And, I can speak for us here at UK. Everything is one aspect of an application. So you've got board scores. Yes, they are important, but an individual is not defined by a single test. And so this is why when we're going through applications, we're looking at every single aspect. So research, volunteerism, personal statements, letters of recommendation. We're looking at everything because we really want to just get to know you. And so to just say, hey, we only look at one thing, that's just not true, because individuals and students are so much more than just a single aspect, one research project, one community service, one test. And so we do a really holistic review of applications here.
Do you require DO students to take both COMLEX and USMLE for your program? And in general, for PM&R, do you recommend for a student to take both or just stick to COMLEX?
I get that quite a lot. So what I will say is for us here at UK, we look at COMLEX and USMLE as they are the same. So we are not requiring or asking DO students to take both the COMLEX set of exams and USMLE. Again, I can only speak to our program, but that is how we do and how we look at things. What I would recommend is if you're looking at different programs, take a look and see if they have that outlined on their website, if they require you to take both exams or if there's certain aspects that they want to see. And then reaching out to the program leadership is always another good step that you can take to see if there are particular programs that you might be interested in as you are in that time of planning to take those exams.
So let's take a step back and talk a little bit about your personal journey. Can you tell us where did you grow up and what initially sparked your interest in pursuing a career in medicine?
I grew up initially in the greater Cincinnati area, and then my family and I moved to northern Kentucky when I was in the 6th grade. And really my pull to medicine was my father. So he was a chiropractor. And so got to spend time at his office, got to see the patients that he was able to take care of. But then I wanted to utilize those manual manipulation skills, but then also I wanted to do more, do some injections, etc. And so when I was looking at options, that is where being a DO came into play. And so when I said, okay, I'm going to apply to medical school, I knew I wanted to be an osteopathic physician because I wanted those manipulation skills in my toolkit to be able to take care of patients.
Can you tell us where did you go to undergrad, graduate school? And was there a specific experience during your undergrad journey that also watered your seed of into medicine?
I went to Wilmington College in Wilmington, Ohio. And as I mentioned, I knew I wanted to go into medical school pretty early on. And PM&R really came into the light when I was in undergrad. So I was introduced to the field of rehab through a sports injury myself. So I played 2 years of college baseball, came down with a shoulder injury as we were getting ready for the season and attempted to rehab it through different methods, and then had a really close family friend who was, at that point, he was an orthopedic surgeon. He said, hey, Nick, I would probably advise you not to go back, especially if you want to do injections, really have full use of your arm. From a shoulder perspective, I said, okay. I said, well, you've sold me. I'm going to hang up the cleats. And then I went back to the rehab doctor that I was working with. I said, "Hey, you're doing some awesome stuff. I would love to shadow you." And then talking to him, he was a general PM&R doctor who did a little bit of everything, took care of patients that had shoulder issues, knee issues, just like myself. I had a shoulder issue. Also did interventional spine injections. And so when I got to see what he did, I said, wow, this is a really cool field. And then went to Lincoln Memorial University, DeBus College of Osteopathic Medicine in Harrogate, Tennessee. And at that point, I knew I was looking at PM&R. Also, as I mentioned, I had a really close family friend who was orthopedics. But then I fell in love real quickly in my first year with PM&R, had some really awesome mentors, and the rest is history.
Did you have any special activity that you did at your school, or was there any specific people at your medical school that really impacted your medical journey?
From an interest standpoint, I was a part of our local AOC PM&R chapter. So that's the American Osteopathic College of PM&R. So I was involved with them from the local perspective, and then had two really near and dear mentors, Dr. DeJuan Perry and Dr. Michael Whiting. Those are two still mentors to me to this day. And they helped, as I had questions, they helped answer everything I had about PM&R. And then really the community that I had with AOC PM&R. So I started off as like a general member and wanted to take on more responsibility. I think at one point, I was the secretary. And then as I continued to work throughout medical school, I continued to want more responsibility. And now I get to say, I'm very proud to be the vice president of AOC PM&R. And it's really through the amazing mentorship through the college. That is something that has really helped me and supported me and has really been there at every step of the way.
That's really cool that you continued with it even to now to kind of pay it forward or help other students through their journey. Also found that you did a year of OMM or anatomy pre-doctoral fellowship at your school. Why did you decide to do this? And can you tell us a little bit about this experience and how did it really shape your approach to medicine?
How our school had it structured is after our second year, once we went through step one, we kind of paused our rotations and said, okay, we are going to spend time as an OMM and anatomy fellow. And so what I was able to do is work with both first and second year medical students. So worked in the OMM department really throughout the entire year. And then in the anatomy lab, I was a teaching assistant for the blocks, including musculoskeletal, because I knew that's what I wanted to do. So I really wanted to get into the lab. And then also the neurologic system. And so those were the two main systems that I got to help teach. And I've always liked teaching, but was really able to hone my skills there just because you're teaching anatomy, teaching OMM, and they're so interrelated. And there were a lot of students. And so that was a really awesome opportunity that I'm very grateful that I got to do. During that time, we also had an OMM Fellows Clinic, so I got a little taste of what it was like being in a clinic, running a clinic with our preceptors. And then during that time, we took some courses to then, at the end of the year, get our master's in anatomy. And so was able to utilize that knowledge throughout residency and still to this day. That was really important to me as I was pursuing a career in PM&R and just the additional musculoskeletal and neurologic anatomy that I was able to learn.
How was your residency application process? How did you choose which programs you want to apply to? And was osteopathic recognition important in this application process or programs you're looking at?
When I sat down to really start looking at programs, I sat down with my wife and we looked at different areas of the country that we would definitely love to be a part of. And we wanted to be close to family. And so first off was some geographical preferences, which now you can put geographical preferences. Back when I was applying, that was not a thing. And then I literally took out a pen and paper and all of the programs that we looked at, I went to their websites and I put a pro-con list. And I looked at general aspects of the program and then things that I could glean from the website And that's where I came up with my initial list. And then as we got into the interview process, I was able to use that list to then ask questions to the faculty, the program directors, the residents, to then really hone my list. And to me, being able to utilize osteopathic manipulation was really important. I wanted to not only be able to utilize it, but learn it. And so here at UK, we didn't have formal osteopathic recognition at that time, but we had a faculty member that was utilizing a lot of it. And I got really close to this faculty member, and he taught me a ton as to how to utilize it and what patients and different techniques. And so I was able to hone those skills. And now I am proud to say that we are one of 3 PM&R programs that are osteopathically recognized. Not only do I think that is important from a patient standpoint, osteopathic manipulation is something that can be really utilized to really help our patients. But now to be able to offer that in a formal venue for residents, I think that is really important to have the specific OMM didactics and workshops. And so now to be able to bring some formality to that and be able to offer it to residents, I think is a really awesome aspect.
How was your residency? Was there a difference in experience between DOs and MDs?
Here at UK, we are very DO-MD friendly. So it really doesn't matter about the initials behind your name. At the end of the day, we want to graduate great residents and even better people. There was no difference in experience. There were some opportunities that being a DO, I said, hey, I'd love to spend some time with Dr. Holland was doing osteopathic manipulation. I was able to spend some time into his clinic, but besides that, there is no difference.
How is the process of finding a job after you graduate?
This is my first job. I went to sleep on June 30th as a previous chief resident and woke up the next morning as an attending ready to take on the day. So I have been here. I have loved every aspect of it. I genuinely love what I do. Going back as to the job process, it's really interesting. I knew I always wanted to stay in academics. I love teaching, very passionate about student and resident education and advocacy. But then also I did look at some private practice opportunities. And when I looked at just different options and different opportunities that were there, I was really grateful to be able to be offered this position. And yeah, I've been here ever since. But that's where you want to look at what residents are doing when they graduate, because not only you see a couple people in private practice and you think that's what you might want to do, you can reach out to them and have that connection to say, hey, you went through this residency, this is what you're doing now. I'd love your input. Or if you see that a couple people do fellowships and maybe it's a fellowship that's close to you at a program that you're interested in, reaching out to them and saying, hey, I see that you're doing a brain injury medicine fellowship. I'm really interested in that. Can you tell me a little bit more about your experience in residency and how that got you prepared for fellowship? And so take a look at where the senior residents go, because that will really give you some good connections and some good talking points to different individuals. You can start developing those connections pretty early.
Our grand finale question: what was the best piece of advice you got throughout your education that you always think of and want to pass on to other students?
My piece of advice that I got that I always give people when I get asked this question is to be okay with not knowing something. We are in the medical field, from starting to pre-med to medical school to residency, we are always expected to have the answer, whether that is from the attending that's asking you questions to the test that's asking you questions. You're always supposed to have the answer. And yes, we are, but sometimes we just don't. And that is okay to not have it. And so it is okay. I'll have a patient that if they ask me a question I don't know, I said, you know what? I think that is a great question. Let me look it up for you and I'll get back with you. And so that is almost a sign of humble. And our brains are not computers. We don't know every single thing that there is to know. Making sure you follow up on it and that you use that as a learning opportunity.
Thank you so much for your time and for talking to me today and answering all my questions, learning about your journey, and really appreciate it.
Absolutely. Thank you so much for having me on.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.